Welcome to you all to the endourology session, a clean bill of health, post-surgical and recurrent infections. Urinary infection, its occurrence, its prevention, and its treatment are an integral part of endourology, and I'm confident this session will highlight developments and current thinking in the management of urinary infections. Vaccination is a hot topic, whether it's for COVID or urinary tract infections. Some of the patients with recurrent UTIs are desperate for a solution to their ongoing and recurring problems. Mr. Steve Foley and Mr. Bob Yang have done outstanding work on vaccination in UTI, and we are very keen to hear all about the vaccine and its efficacy. Could this form a regular part of the armamentarium in the management of UTIs? Their talk will tell us. Ms. Pravisha Ravindra will explore and let us know the role of intravesical treatments for refractory UTIs. Again, I'm sure we are all keen to know its efficacy and the algorithm that we need to follow in the management of recurrent UTIs. Patients with stones, stents, nephrostomies, etc., are inherently have colonized microorganisms. Surgery in this situation can be potentially dangerous with infection related complications and even sepsis. Dr. Bruce McRae from University College London will talk to us about microbial optimization and prevention and treatment of these infections. I am sure we are eagerly waiting to hear from you, Dr. McRae. Professor Bhaskar Somani from Southampton needs no introduction to BAVS members and the endourologists in the UK and abroad. Recently, he has been the proud recipient of Arthur Smith Award. He has done a lot of work in various aspects of stone disease and endourology and has published widely. We look forward to hearing from him on ureteroscopy and infection. A warm welcome to all speakers and to every one of you. I'm sure this will be an interesting, educational, and guidance session for urinary infections. Thank you.
Good day, everyone. We're talking today about vaccines and their use in urinary tract infections. We live in interesting times. I used to say that antibiotic resistance was the biggest threat to world peace and compared to Donald Trump. I got that one wrong. I think Donald Trump's won that race. But we in Reading are always looking for opportunities and options that aren't antibiotics for our patients. And the idea that these patients have deep-seated, embedded infections, I think is only part of the story. There's a group of patients here that have their natural immunity, whether that's vaginal estrogens they need, whether it's bladder installations that they need to make their bladder stronger, or whether it's actually the vaccines that can help their overall immune system. I think there's several options that need exploring for your patients that aren't just antibiotics all the time. In this section, we're going to cover the use of vaccines that we've been heavily involved with in Reading. And I think people should start thinking about this as an option for your men and ladies with chronic urinary tract infections. I'll hand over to Bob to present that, and we'll discuss a bit more at the end.
Hi there, my name is Bob Yang, and I'm going to talk about the vaccinations currently available for recurrent UTIs. So as you know, vaccine is the hot topic of the day with COVID going around everywhere, Daily Mail really going for it. We're all pining for the vaccine, hopefully by Christmas time, or hopefully even maybe we'll know by the time this recording comes out. And you can see from Google Trends, the Googling for vaccine really has taken off since November 2019. But specifically for UTIs though, what are our options available? So the first one is something called Uravaxone. In literature, it's originally called OM89, and it's one of the first UTI vaccines developed, registered in 1987, and it's composed of 18 uropathogenic E. coli strains, which, as we all know, is the most common responsible pathogen in UTI. It's an oral tablet, dosage is once a day for 3 months, and the actual pathophysiology behind it is that the tablet passes through the stomach, so it's resistant to the digestive proteases, where it's then absorbed in the gut, mainly the jejunum and the ileum. The antigens within the tablet is then presented to the pair patches by the antigen-presenting cells, which then activates a cascade of immunology for both the innate and then subsequently the adaptive immune system. So in mice experiments in vivo, what OM89 has shown to do is increase both the IgG and the IgA, so the adaptive and the innate immune system, to both to all 18 pathogenic strains of E. coli. But importantly, when we test the response of the serum to other uropathogenic strains outside of the original 18 E. coli strains, there actually is a response as well. So potentially, therefore, it may provide a broad spectrum response. And in addition to this, there's also an anti-inflammatory response seen in the tissues after treatment with OM89. So the actual evidence itself, well, the early results were rather positive. As you can see, double-blind RCTs in varying numbers of patients show a decrease in UTIs when compared against placebo. 2005, 453 patients. So overall, a decrease in the actual UTIs. But when we look at more recent data, so this one in 2015, unfortunately, this data doesn't actually show much of a difference. So they compared OM89S against placebo and nitrofurantoin prophylaxis, and they found no actual difference between the rate of UTIs. However, for this study, the overall rates of UTIs were rather low, so care is actually needed when interpreting the data. And furthermore, the vaccine used in this study was OM89S, which is manufactured in a slightly different way to OM89. And thus, we do not know whether that has changed the potency of the vaccine. To note as well, OM89S is no longer being produced. A more recent UK data by Brody et al. In 2020 shown that in both women and in a very small cohort of men, retrospectively, that OM89 does decrease the number of UTIs, and in fact, it halved the number of UTIs in a subsequent 12-month period after treatment compared to the number of UTIs these patients had in the 12-month preceding treatment. And so as a result, Urovaxum has made its way onto the current EAU guidelines, though the strength of the evidence is still considered rather low. The more recent thing, however, is Euroimmune, which is, I'm sure a lot of you had heard us talk about in the past. So Euroimmune is the new UTI vaccine, and how it works, essentially that there is the genital urinary tract harbors both an innate and adaptive mucosal immune system called MALT. And over the recent years, it has been found that stimulating the mucosal tissues at one site induces an equally strong response at a distant mucosal site. So as you can see in the picture on the right-hand side, when studied using cholera toxin B in humans, induction at a certain site causes an immune response in both the stimulating mucosa, so the mouth, the rectum, the vagina, etc., as well as the interconnected distant mucosal site. And the strength, the darkness of the shading corresponds to the strength of the response. And so importantly for us in UTIs, stimulating the sublingual system has been found to induce a response in the genital urinary system. And furthermore, due to the similar lipopolysaccharide outer membrane on both uropathogens, this immune response is broad spectrum against other uropathogens found outside of the actual stimulating vaccine itself. So Euroimmune, it's a spray, it's sublingual, and it's composed of 4 inactivated whole bacteria. As you can see there, E. coli, Klebsiella, Proteus, and Enterococcus. It's a 3-monthly course under the tongue, and it actually tastes like pineapple, as reported by our patients. The initial 2 large retrospective studies were from Spain and were rather positive. So they were by a group from called Lorenzo Gomez et al. So their initial study in 319 patients found that when compared to cotrimoxazole prophylaxis, as you can see here, a much greater number of patients treated with Euroimmune, seen in the blue bar, remained UTI-free than those on antibiotic prophylaxis, and their follow-up was at 3 months, 9 months, and 15 months. And importantly, they noted no side effects at all. Whether that is because it's retrospective or not remains to be seen. So the same group then did a further study, a second study, more patients, 669 patients, and they approached in a slightly different way. So they used Uramune for 3 months in the first group, compared to a second group who had 6 months of low-dose antibiotic prophylaxis. And then both groups were then monitored for 12 months on 0 treatment, so no treatment at all. And as you can see, by 12 months, only 9.7% of patients who had Uramune developed subsequent UTIs, whilst compared to the group who had prophylaxis that was stopped, 100% had developed a new infection. And quite strikingly, this graph just shows how quickly the number of UTIs, number of patients develop UTIs in the antibiotic group when compared to the Uramune group. So in the UK here, we led a prospective study in 77 patients with recurrent UTIs who has failed conventional therapies. Now, these conventional therapies include low-dose prophylaxis, but also included people who failed intravesical treatment, Hiprex, D-Manos, etc. As you can see, almost all our patients successfully completed our treatment course. And most importantly, of the ones who did complete the course, 78%, so a very large number, remained UTI-free in the subsequent 12-month follow-up. Not surprisingly, though, we found Uramune was less effective in the postmenopausal women, likely due to their estrogen deplete state, increasing their risk of UTIs. But still, 72% effective, but much more effective in the premenopausal cohort. Admittedly, for Uramune, there's no RCTs currently published, but I can tell you now that an international multi-center RCT between Reading, so here, and Spain has been completed, and we will be sharing the data shortly, hopefully at the next BOWS meeting. So then we move on to 2 smaller vaccines. Urovac, this was a vaccine which showed potential initially. It's a vaginal suppository composed of a variety of E. coli strains, but also other bacteria as well. And it's a 3-week course follow-up, followed by some booster doses. But really, it hasn't taken off since 2007. There's been a meta-analysis which shows in 3 RCTs, it does decrease the number of overall UTIs, but it's really falling out of favor when compared to the current oral options available, which we discussed previous to this. And the other one, just to be aware of, is XPEG-4V, so it hasn't really had a name yet. And this is more this is a single injection in the muscles, an intramuscular option, really more akin to what our patients or the public perceives to be a typical vaccine. However, there's only 1 RCT for this therapy, which in 93 women showed a rise in the actual IgG levels specific to the antigens that is contained in the vaccine, but there was actually no reduction in the overall UTI rates. So overall, lots of potential, especially Uramune and Urovaxon, and we look forward to what the future brings.
So hopefully, having listened to some of the data, some of the presentations, then it will stimulate a number of the people watching today to look at the idea of vaccines for your patients. I think if you've tried everything else, if you've been down the antibiotic route, if you've optimized their estrogen levels, if you consider bladder installations as an option, I think the vaccines should be another line to investigate. I think historically, we've had Urovax, and I think many people were put off by the low levels of response from that vaccine. But I think it's just one stage in the development of vaccines. And I think the more information we get, the more we develop, the more exciting it gets. I think Uramune is a step up from Urovax. The RCTs will be published next year, and the data is looking really exciting. We were hoping to do a further RCT this year, but there seems to be a pandemic getting in our way and interfering with the research in this project. So I would encourage all of you to look at this as an option. It is available on a named patient basis in the UK, and hopefully once the trials have been published, we could start to talk to NICE about the options of getting this as a first-line treatment. In our practice, we'd optimize everything we can, as we've already said, and the vaccines will certainly be part of that optimization. If you need any more information, it's available from myself or Bob. Happy to talk to anyone offline. Thanks very much for listening.
Hello, my name is Pravisha Ravindra and I'm a post-CCT fellow in functional and reconstructive urology at the Queen Elizabeth Hospital in Birmingham. I'm about to start as a consultant urologist in Leicester. In the next 10 minutes, I'm hoping to provide a whistle-stop update on the evidence for intracycle treatments for refractory UTIs. I think in the first instance, it's important to have it clear in your head where this fits into your treatment pathway. We all see patients with current UTIs, and we can debate the evidence for and against many of these strategies in another talk, but based on current evidence, this is a reasonable and common treatment pathway. I work my way through over-the-counter and non-antibiotic treatments before considering short-course prophylaxis. But if at this point we're unsuccessful or the patient is developing resistance, I would refer them to infectious disease. If this service is not available locally, then I would have a discussion with a microbiologist who may have an interest in UTIs. You could do this concurrently while initiating the patient on a commercially available installation, but I think it is helpful to have a fresh set of eyes cast over the patient. So how do they work and how are they different? And I think key to understanding this is understanding the gag layer and the bladder. It was initially identified as a mucus layer on the surface of the uroepithelium, which is responsible for the barrier mechanism of the bladder. Heparin sulfate, dermatan sulfate, and chondroitin sulfate are linked to a protein via serine residue. You should note that hyaluronic acid is not found linked to any protein core, but is produced out into the extracellular space. So work looking at the gag layer, it showed rabbit bladders deficient in gags had a significantly higher infection rate compared to bladders with intact gag layers. It's thought to have a protective function by preventing the adhesion of pathogenic bacteria to the bladder epithelium, which is a key step which contributes towards the virulence, particularly in recurrent UTIs. Damage to this layer is thought to be one of the underlying mechanisms of recurrent cystitis in adults. It's also thought that defects in the gag layer facilitates the entry of urinary irritants like potassium, which then triggers the pain and bladder hypersensitivity reaction, which is characteristic of bladder pain syndrome. So what's available? You have hyaluronic acid only options, so that includes cytostat and HyCys, chondroitin sulfate only options, Uracyst and Gapan and Still, although these aren't commonly used in this country. And then finally, one that combines the two, which is known as ialurol. You'll also find the following intracycle treatments in the context of bladder pain syndrome, a variety of different cocktail combinations, most commonly Parsons cocktail. Essentially, these consist of a heparin bicarbonate local anesthetic with or without antibiotic prophylaxis. There's also pentasan polysulfate, which is a synthetic polysulfated xylan. So it's a synthetic gag component, otherwise known as Elmeron, which can be given intracyclically. There's also now increasing evidence for intracycle antibiotics. So what's the evidence? As with everything, we start with an animal model. So this is a rat model. It showed that there was significant median bacterial growth rates in control rats versus those in SIL with hyaluronic acid, chondroitin sulfate, or a combination of the both. There was a significant reduction in median bacterial growth rates in the group that had hyaluronic acid and combination therapy, and the transitional epithelium damage decreased in the treatment groups, most prominent in the combination group. There were two cohort studies which looked at hyaluronic acid only replacement. The first one had 20 patients, the second one had 40. Both showed a significant decrease in UTI events. The first went from 5 to 0.5, second from 4.3 to 0.3. There's also an increase in time to recurrence from 76 to 178 days and 96 to a monumental 498 days. The evidence for chondroitin sulfate options are limited. There was one large non-interventional study of 286 patients. This was a complete mixed bag of bladder pain syndrome, overactive bladder, radiation cystitis, and recurrent bacterial cystitis. The authors found a significant improvement from baseline for urgency, frequency, and pain at 3 months, and overall 82% of patients and 84% of doctors gave a positive global rating on the treatment's effectiveness. The greatest amount of evidence exists for a combination of chondroitin sulfate and hyaluronic acid. There's one randomized placebo-controlled study of 57 patients. So this showed a significantly decreased UTI rate and a significant increase in mean time to recurrence. What they showed was that it went from 52 days to 185 days. The next study randomized patients against antibiotic prophylaxis. This showed a significant decrease in UTI episodes at 12 months, but not to suggesting that there may be a cumulative effect in the number of treatments that you have. Another multi-center cohort study supported the previous findings, but also suggested the risk factors for new UTI episodes were being older and having more frequent episodes, so more than 4 UTI episodes a year. And again, it seemed to work against antibiotic prophylaxis. The most common combination used in these studies have been a combination of sulfatrimoxazole and trimethoprim. There was then a much larger multi-center case control study comparing 276 patients. So 181 were treated with a combination therapy and 95 patients were treated with standard of care. This included prophylactic antibiotics, cranberry tablets, probiotics, and one big criticism of this study is how heterogeneous the standard of care cohort is. So while they showed a 49% reduction in UTI risk recurrence, nothing else was significant. They did, however, show that the benefit improves when the number of installations was 5 or more, which also supports the cumulative effect theory. This is a great meta-analysis by my colleague Jonathan Goddard that put all these studies together. And as expected, the treatment effect was most pronounced when the control groups did not have antibiotic prophylaxis, which isn't so much of an issue because that's the very thing that we're trying to avoid. Interestingly, though, when the results were pooled, better results were seen in the hyaluronic acid only group versus the combination group, although this is likely to be due to the mixed patient population in Gianni's study, which may have weakened its conclusions. There was no specific literature that addressed the role of cocktails in recurrent UTIs, but there was an increasing body of evidence which looked at intrathecal antibiotic installations. This has been pulled in a fantastic review by the next speaker, Professor Samani. There were a number of studies summarized, and overall the patient population was over 280 patients. The group consisted predominantly of neuropaths, patients with indwelling catheters, and various bladder reconstructions, including augmentations. There were a range of antibiotics used, most commonly gentamicin, but also a combination of neomycin and polymyxin, neomycin on its own, and colistin. The two different approaches, so the first one was prophylaxis, so prevention of recurrent UTIs. The second one was treatment of particularly refractory UTIs. Overall, there was a 78% reduction in symptomatic UTIs and good tolerability. It was felt to be much more successful in the treatment group compared to the prophylaxis group. Although what the authors did point out is that there was a change in the sensitivity of organisms in just under a third of the patients. And therefore, I would really advocate this strategy to be employed in concert with infectious disease and microbiology. So this is where we are. As you can see, the evidence for commercially available installations and the treatment of recurrent UTIs is heterogeneous and of varying quality. The most evidence exists for a combination of hyaluronic acid and chondroitin sulfate installations, and this appears to offer at least an equivalent, if not more effective, management strategy than prophylactic antibiotics, particularly in this era of antibiotic stewardship. And finally, there's a growing body of evidence for intracycle antibiotic treatment, but I think due to the risk of changing organisms and sensitivities should be undertaken in concert with infectious disease and microbiology. Thank you. Just thought I'd leave this here as a reminder of a time when we could go to conferences in person and buy tacky, amazing merchandising. Thank you.
Good afternoon. I'm a microbiologist and I've been asked to talk about the pre-op microbiological optimization of the urology patient. To tackle this question, to tackle this topic, I ask the question is, what can be done preoperatively that will decrease the risk of infection in the postoperative period. So I will be speaking about asymptomatic bacteriuria, but the title of this talk requires a little bit more than that. We're currently in the middle of a pandemic. We are all working under new workflows that require the screening for SARS-CoV-2. This is to ensure that the patient does not present with infection in the postoperative period when there's an increased morbidity and mortality, but it's also to manage the risk to other patients and the risk to staff. We also sometimes screen for specific resistant organisms. So we screen for MRSA in patients having surgery with the insertion of prosthetic material. Some centers screen for extended spectrum beta-lactamase producing coliforms before transrectal prostatic biopsy. And in some patients with specific risk factors, we screen for carbapenemase producing coliforms. I'm not going to be addressing these specifically. So I want to move to asymptomatic bacteriuria treatment and its impact on the postoperative infection. There's agreement that there's strong evidence for its impact in some surgeries, so transurethral resection of the prostate, stone surgery, but there's weaker evidence in others, such as cystoscopy, lithotripsy, transurethral resection of bladder tumors. There's acknowledgement that because the incidence of urinary tract infection is often low in some surgeries, it's difficult to get the numbers that would allow a proper study of the impact of asymptomatic bacteriuria treatment on postoperative infection. It's important to consider what we're trying to achieve when we treat asymptomatic bacteria. Let's go back to the conventional categorization of surgeries, such as either clean, contaminated, or infected, dirty. Untreated asymptomatic bacteria means that there are bacteria in your surgical field. So that means it's a contaminated procedure. Obviously, treatment of the asymptomatic bacteria changes that back to a clean, contaminated procedure. At UCLH, we were asked to review our pre-op pathways. It was felt that our surgery cancellation rate was higher than it should be. We asked ourselves, why was that? And at the time, we were screening for and treating asymptomatic bacteria in the weeks before the surgery. When the patients subsequently presented for the surgery, they were checked for new urinary tract symptoms and a urine dipstick was performed. A patient that had a positive dipstick was then assessed to see if the surgery could proceed, often resulting in cancellation because of surgical or patient risks. I'm sure all of you will be familiar with the weakness of using dipstick in this setting. Following a review, we changed our pre-op pathway. So we started screening for asymptomatic bacteriuria in the 3-week period before the surgery. And if the urine was positive, we arranged for the prescription of an appropriate oral antibiotic to be taken in the 3 days before the surgery. As it says in the European Association of Urology document, we control the bacteriuria into the procedure. When the patient presents for their surgery, there's no need for a urine dipstick unless they've got new symptoms. If there are reasons why the patient can't take oral antibiotics, they are given intravenous antibiotics for a period of 24 hours before the procedure. There is a difference between the EAU recommendation, which suggests 5 days of treatment, from that of the American IDSA recommendation, which was for 3 days of treatment. But in the latest guideline published last year, they suggest that a shorter course may be possible. Of note is that we follow the similar process for asymptomatic candidiuria, and in that case, we do continue the antifungals for a few days post-procedure. I need to say that this pathway has been made much more difficult by the need for a pre-op SARS-CoV screen. So how did we tackle the project? So we involved 3 groups really, so the microbiology laboratory, the pre-assessment clinic team, including perioperative medicine fellows. We involved urology teams initially with the Stones team, and then expanded to the other teams in the UCLH urology department. In the microbiology laboratory, what work was done? Essentially, conventionally, we report positives as low as 10 to the 3 organisms per mil. For intraoperative urine specimens, we even go lower. Asymptomatic bacteriuria uses a cutoff of 10 to the 5 organisms per mil. So one of the challenges is, how do we identify these urines where we're screening for asymptomatic bacteriuria in the laboratory? What we did is we developed a specific asymptomatic bacteriuria pathway in the laboratory. And the ability to recognize these was made a whole lot easier by the rollout of electronic ordering, such that if the specimen has been requested properly, that the biomedical scientist in the laboratory can identify the requests and therefore report appropriately. The next group that we've worked with was the pre-assessment clinic. I think it was acknowledged is that often the patients who, when they presented for the pre-assessment, some of them had symptoms which suggested a possible UTI, and they actually often needed urine sent off and appropriate empiric treatment when they attend a pre-assessment clinic. The symptom review is not easy. It's how to discriminate in the urology patient between the day-to-day background symptoms and any new symptoms that might indicate a UTI. And we did specific work with the pre-assessment clinic to try and tease out what is a background symptom or what are new symptoms. For the pre-assessment clinic team send the urine, follow up the results, and arrange for the prescription, either for the patient to collect at the hospital or from the GP's surgery. As part of the project, we adapted to using the term ASB in place of UTI. We gave an explanation of asymptomatic bacteriuria as a normal finding, but one that requires specific treatment in the setting of surgery. This rather than always using the term urinary tract infection. And as a consequence, we had to amend our patient information leaflets and our patient and GP letters to give explanations. So lastly and importantly, we come to the urologist. The responsibility for the patient sits with the urology team, and they may well have to do the troubleshooting that is needed to get the patient ready for surgery. In the UCLH workflow, they take the queries from the pre-assessment clinic. My experience has been built by attending the Stones multidisciplinary team meeting. The clinical cases are reviewed and checks are done to see that everything is in place for the surgery to proceed. This includes asking, is there asymptomatic bacteria? Is there a plan for treating it? And is there past history of antibiotic resistances that might impact on which antibiotics we use? What about the standard surgical prophylaxis, where conventionally we use gentamicin? Is there a need to, perhaps because of gentamicin resistance, need to adapt the antibiotic that we're using? We also then discuss a kind of rescue, or sometimes people call it a SOS, to an antibiotic that will actually be, that can be used if there's post-op infection or sepsis. Thus far, I haven't said anything about the antibiotic treatment. Just to say is that what we've done is we created a hierarchy of antibiotics for the treatment of asymptomatic bacteriuria, trying to apply the principles of antimicrobial stewardship. The hierarchy can be seen in the graphic on the right of the screen. the graphic is used by clinical staff when prescribing. The microbiology department also supports this by having a very specific release pattern of antibiotics when reporting these pre-op urines. Our standard release pattern is very simple. It goes back to amoxicillin, trimethoprim, and nitrofurantoin. We also progressively add more antibiotics if we see resistances. So effectively what we're doing from a laboratory point of view is we would release fosfomycin, pivamicillin. I think if there are resistances in those, we would then go down to ciprofloxacin or coamoxiclav. So that is something that the microbiology does regularly. We also release gentamicin for surgical prophylaxis, adding amikacin if there's gentamicin resistance. And as I've already said, we release an antibiotic for post-operative infection. Cefuroxime would be the standard, but if that's resistant, we release other antibiotics using temacillin, ceftazidime, piperacillin, tazobactam, or meropenem as is necessary. So in summary, I've described the work done to manage the asymptomatic bacteriuria on the urology surgical pathway at UCLH, and this to prevent post-operative urinary tract infection and sepsis. We are currently in the process of actually looking at the outcomes of the new workflow. So in the last slide here, I would just like to thank my colleagues, specifically the Stones team, which is where I've learned my urology, pre-assessment clinic staff who've worked on the project, as well as the perioperative medicine team. I've done a lot of work with the urine bench in the laboratory at HSL, and within my department, I rely on the other people to issue and report and release the antibiotics as is appropriate. The end here, I've put some references which I think are useful when actually looking at the asymptomatic bacteriuria and its management. Many thanks.
Hello, everyone. Good afternoon. I'm very thankful for asking me to talk about ureteroscopy and infections and the association it has. I'm Professor Somani and I work in Southampton. These are my relevant conflict of interest. To start off with, complications of ureteroscopy. This is a systematic review with 187 papers that was published recently, and it talks about all sorts of complications, and of course, infections being one of them. And according to this paper, the fever rates between different reported series varies up to 15%, same with urinary tract infections, and urosepsis rates really varies from 0.1 to over 4%. So a big variation. And the question is, how can we predict or how can we prevent complications related to this? This is a ureteroscopy and risk factors for infections meta-analysis that was published recently with nearly 10,000 patients. All of them were comparative studies, and there was no association found with age, stone diameter, or renal insufficiency. However, they found association with pre-op positive urine culture, so that would increase the risk of infections. Females had a higher risk of post-op infection complications, and higher operative times again was more in favor of infections. Looking at other aspects, diabetes mellitus, as you would expect, was associated with high risk of infections, and both pre and post-operative stents were associated with high risk of infections. When we look at different series that have been published for different aspects, so this is the Crow's global study where the use of access sheath was found to decrease the risk of infection complications, but no difference in stone-free rate. This was one of our series, and higher operative time was associated with high-grade special infection complications. This paper is a landmark paper and shows that stent dwell time and also female gender was associated with sepsis, and they recommend to perform ureteroscopy within 1 month of stent placement. And then tailoring the antibiotic to local resistant profiles would help reduce infection and sepsis. And this paper recommends tailoring it based on local resistance. Again, looking at what type of prophylaxis, this paper talks about single dose of preoperative antibiotic, oral antibiotic, they say was enough. Again, in this paper, the correlation was seen with especially females with a history of previous sepsis, antibiotic therapy, stents, positive culture, or if they had residual stones. These were all risk factors for sepsis. And then again, risk factors for fever and SIRS was seen by longer surgical time, medical complexity, and positive culture. So there is a theme towards it, and we think we can identify the risk groups here. We did a ureteroscopy and urosepsis predictor through ULIS, a systematic review, and this was looking at high volume endourology centers. So what we did was to look at published series with over 400 patients as a minimum that reported an infection complications and that were related to stone disease. So non-stone disease were excluded. Of this, we found almost 25,000 patients, and the complications and risk factors that followed, the overall complication was 7.9%, and the infectious complications of these was about 4%, mostly fever, but urosepsis rates is not negligible. So what are the preoperative risk factors according to this paper? Gender, age, high BMI, comorbidities, stone size, and stone burden. So if it's a bigger stone, you have a higher risk. History of previous urinary infections and positive pre-op culture, stent dwell time, and previous indwelling catheter or neurogenic bladder. Now, when we look at intraoperative risk factors, this was the use of ureteral access sheet. So this was found to be protective. Procedural time, use of stents, again, was not protective. So you would have a higher risk. Postoperatively, you needed to identify and treat sepsis early and early stent removal if you did leave a stent. Again, looking at how to reduce then the risk of infections. Patient factors are sometimes non-modifiable. You can ask them to lose weight, but a lot of patient factors, or maybe control the diabetes better, sometimes can be non-modifiable. Antibiotic prophylaxis is a must. Treat UTI. I can't stress anymore, this is absolutely fundamental. Local antibiotic resistance patterns are very important. Keeping the procedural time low, and indwelling stents and stent dwell time, again, if you need to put one, only put one, but keep the stent dwell time low. Access sheet, I quite like it, especially for large stones. We now look at the role of ureteroscopy for kidney stone disease when we talk about urinary infections. So these are patients with recurrent urinary infections, but with associated kidney stone disease. Does treating the stone disease help with infections? So we looked at a 5-year period with more than 100 consecutive patients. And these are patients who either had a positive pre-op culture or a history of recurrent urinary tract infections, stone size just over 16 millimeters. Again, for all time points at 3 months, 6 months, and 12 months, there was a significant association of being stone-free and being UTI-free. So at 3 months, the stone-free rate was 96%, and the UTI-free rate was 88%. And with time, some patients had a recurrence and the UTI-free rate dropped. But the gist of the paper was, if you've got urinary tract infections and stone disease associated with it, treating stones would, in a lot of patients, help with the urinary infections. Going forward, what about patients who present with urosepsis and need an emergency drainage? What is the outcome of elective ureteroscopy for these patients? So again, we looked at a 6-year prospective study, and emergency drainage in the beginning when they presented was either via stent or nephrostomy. Of these patients, more than a third were admitted to ICU, so they were significantly ill. In total, 76 patients underwent 82 elective ureteroscopy procedure with a male to female ratio of 1:2 and an overall stone size of 11 millimeter. Looking at the stone-free rate, it was very good. And the complication rate, 3 patients had UTI-related complications. 2 had UTI that needed IV antibiotics, and 1 urosepsis that needed a repeat ICU admission. So in summary, if we have got a previous history of urosepsis and emergency drainage, these patients, again, do very well with ureteroscopy electively. How do I do it then? assessing the patient's stone characteristics and CT-KUB, informed patient consent and mutual decision-making, pre-op culture and routine blood tests, up-to-date imaging, especially with COVID, there are sometimes delays possible, minimizing pre-op stenting and dwell time, and I know it can be sometimes difficult, but trying to minimize it as much as possible, identifying high-risk patients and patient groups, so these could be your pregnancy or reconstruction patients or pediatric patients, single dose of antibiotic on inductions, unless there is a pre-op positive culture, we give gentamicin, access sheet, especially I use it for large stones, and keeping the procedural time low. So going forward, we looked at the antibiotic resistant trends that was published about 8 or 9 years ago in JCU. And we looked at the antibiotic trends for common antibiotics that included things like gentamicin, which is commonly used, and that had a resistance of about 5%, ciprofloxacin just over 12%, and various other antibiotics. So at the time, we decided that gentamicin was our go-to antibiotic for endoscopic procedures, unless there was a positive culture previously. We then repeated the same exercises 5 years later. Unfortunately, the resistance trends were similar and we could keep the same antibiotic prophylaxis. So this is very important to know what the local resistance patterns for your hospital or your region is. Again, what is the role of single-use electroscopes when we come to management of stone disease? There are various indications, but in context of previous urosepsis or multi-resistant organism, I quite like to use single-use electroscopes. Otherwise, I'd use it for large renal stone or lower pole stone more than 1 centimeter, or if there's any abnormal anatomy. Looking at the role of high-powered laser, and why do I talk about this? Because when you use a high-powered laser, the operative time can be minimized, and if you minimize operative time, you decrease the risk of infectious complications. So here we have 50 patients who had stone mean diameter of more than 2 centimeter, and the mean operative time 51 minutes. So it's really good and good stone-free rate. So in these patients, we have large stones. You should try and have a high-powered laser so you can go quicker in some ways and reduce the operative time. So to conclude, urinary tract infection and urosepsis can be minimized by adequate pre and intraoperative precaution. Successful ureteroscopy in patients with kidney stone disease leads to resolution of UTI, and elective ureteroscopy in patients with previous urosepsis and emergency decompression achieves excellent outcomes. Thank you so much.
Ladies and gentlemen, I'm sure that you will agree with me that we had excellent exposition on all aspects of urinary infections. All the talks had a very clear take-home message and are very useful in our day-to-day clinical practice. Steve Foley and Bob Young gave a comprehensive overview of the status of vaccination in recurrent UTIs. It's becoming clear that the vaccine Euroimmune holds promise, and perhaps more of us should start using them in the right patients. Pravisha Ravindra gave a great talk and clarified the place of intravesical treatments in the management of refractory UTIs. The evidence for commercially available installations is heterogeneous. The most evidence is for HA and CS. UTI frequency is reduced and there is an increase in time to recurrence. Longer treatments may be beneficial. There may be a role for intravesical antibiotic installation in selected patients. And the concept is evolving, and watch this space. Dr. Bruce McRae gave an illuminating talk on the novel concept of preoperative microbial optimization. This prevents postoperative urinary infections and sepsis. That's a great concept. Professor Bhaskar Somani clearly showed evidence that higher operation time, stent dwell time, high BMI, and female gender were at an increased risk of postoperative urinary infection following ureteroscopy. An access sheath decreased the risk of infection, although the stone-free rates did not change. The take-home message was careful preoperative and intraoperative precautions decreases the postoperative infection. My sincere thanks to all the speakers and to every one of you for virtually attending this session. Thanks.